So without further ado, I would like to introduce our first speaker, Dr. Lorrin Koran. He has an extensive CV, but I do want to highlight that he is the founder of the Stanford OCD Clinic. And he is retired now. He's professor and emeritus, but still doing research, publishing papers, really uncovering amazing science, and also that's bridging, across disciplines. He is a sponsor for junior faculty and just a wonderful person. And when I first came to Stanford, individuals who had worked with Dr. Koran were just singing his praises, and it's so lovely to see that he's really touched so many lives, and it's just such a pleasure to know him. I've also been inspired by a book that he wrote, Obsessive Compulsive and Related Disorders in Adults, a comprehensive clinical guide. In addition to being a lovely clinician, he's also a really gifted writer. So without further ado, Dr. Koran.
Carolyn, thank you so much for such a, I don't know, over-the-top introduction. I'm not sure I deserve all that, but it's a pleasure to be with you and a pleasure to try to pass on some information. I'd like to invite anybody who wants to email or look up OCD research at Stanford, and you can request an educational handout that I prepared for patients when they would come to the OCD clinic, along with the American Psychiatric Association treatment guideline for OCD and the update to that guideline. And those documents will have lots and lots of information that might be useful to you. So with that, Carolyn, we can start with the slides. So that we're going to talk about medication strategies primarily for resistant OCD, that is people who have not responded enough to these first-line treatments. These are the starting treatments. And I'll just say a few words about these. There are cognitive behavioral therapy of a special kind called exposure and response prevention is very effective. Perhaps 50 or 60% of people will respond well to it. And medications like serotonin reuptake inhibitors also help about 40 to 60% of people who try them. And people's response is to reduce their OCD on a rating scale called the Y-box, the Yale-Brown Obsessive Compulsive Disorder scale, by 25 to 50%, sometimes 60%. And that makes people feel a lot better, but they don't get rid of all their OCD, unfortunately. Excuse me. The problems with CBT are that it's time intensive. That is, you go for a session, you have to go to the doctor's office usually, although now with social media, I think it can be done and is being done over the web. But it's also less accessible because not every psychologist and certainly not every psychiatrist knows how to do this particular kind of CBT. The medications, while effective, have downsides as well. Side effects, particularly sexual side effects, bother people, but it's important that you know that those sexual side effects can be treated. There are other ways to counteract those side effects. And then there are drug interactions if people are taking other medications. It's also important to know that higher doses of the serotonin reuptake inhibitors are more likely to work, and they are more likely to produce bigger effects than lower doses. But of course, treatment is individualized to every patient. My practice was to start at a low dose and then every week go up by one dose step to the highest dose that the patient could comfortably tolerate. And then you have to wait 6 to 8 weeks to see if it's going to work. And once it starts working, once people start to feel better, they get the most they're going to get from that particular drug at that particular dose after about 8 weeks. And that's when you can make a judgment as to whether something more needs to be done. Also, it's very helpful to combine cognitive behavioral therapy and an SSRI, a serotonin reuptake inhibitor. You may get both a larger effect, and after, let's say, roughly a year of combined treatment, or you can taper off the drug and you're less likely to relapse than if you just got better from the drug alone. The CBT can have long-lasting effects. Next slide. So we're going to review some things that you can bring up with your doctor if those first-line treatments don't work enough. And we'll talk about caffeine in pill form, dextroamphetamine, a stimulant used to treat attention deficit disorder, memantine, which is a drug used to help people with memory and learning and cognitive function in Alzheimer's disease, lamotrigine, which is an anticonvulsant. It's a drug used in epilepsy. It's also used in bipolar disorder, manic depressive disorder. And then finally, morphine in the form of once a week dose by mouth. So we'll review those 5 alternative treatments for people who have not responded to, not necessarily their first treatment, because usually you would try 2, maybe even 3 of the serotonin reuptake inhibitors, and or you might add what's called a dopamine blocker, a so-called atypical antipsychotic drug. Drugs that block dopamine receptors in the brain and were initially used for schizophrenia, but are now used for bipolar disorder, OCD, treatment-resistant major depression, but they're still called atypical antipsychotics or dopamine blockers. So let's go to that. We'll talk first about dextroamphetamine, the drug used for attention deficit disorder, versus caffeine, which was used in a study that we did here at Stanford that I'll tell you about. From the 1980s, there are 2 one-day studies of dextroamphetamine, a single dose given on one day and a week later given placebo, or maybe they started with placebo and a week later they got dextroamphetamine. It was double-blind. And in both of those, 10 or 11 out of 12 patients got better on the dextroamphetamine day, and none of the patients got better on the placebo days. There's also a case report of Adderall, which is dextroamphetamine and amphetamine mixed together. One person reported with OCD got better. And then there are 4 cases of children with OCD and attention deficit disorder who, when given Adderall added to their SSRI, their OCD got much better. So having read those and having a lot of patients in the OCD clinic who were not doing as well as both of us hoped, I decided to do a double-blind study of dextroamphetamine, and I chose caffeine as a placebo because I didn't want the patients or us to know if they felt stimulated that they were getting dextroamphetamine, and if they didn't feel stimulated, they were getting sugar pill. So we chose caffeine as our placebo control, and we got quite surprised. Next. These were all adults. They had a moderate to moderately severe case of OCD. They'd been on whatever drug they were taking for at least 12 weeks at a steady dose. They didn't have certain other disorders where they could confuse the picture, or it wouldn't be a good idea to give dextroamphetamine. And they were randomly assigned to either dextroamphetamine, D-amphetamine, 30 milligrams a day, or caffeine, 300 milligrams a day in pill forms. So for both dextroamphetamine and caffeine, people got 2 pills so that we could decrease the dose if we needed to. And in the first week, we called everybody every night and had them do a Yale-Brown obsessive compulsive scale rating with us. And if that got better by 20% by the end of the first week, then they could continue in the study for 4 more weeks. Next slide. So there were 24 patients, 11 women, 13 men, mean age about 40. Most of them had had onset of OCD in their teenage years, some in their childhood years, a few in their up to the 20s. It's unusual for OCD to begin after 25. And they were moderately severely to severely affected by OCD. A Yale-Brown score of 25 is moderate, and 30 starts to be severe. So they were they were really suffering. And many of them had other disorders as well. Major depression, dysthymia, which is chronic low-grade depression, GAD, which is generalized anxiety disorder, And one patient had social anxiety disorder in addition to OCD. Next. Next slide. By random chance, half got amphetamine and half got caffeine. There were no differences in these two groups, except that more caffeine subjects were taking a dopamine blocker. That is, the drugs I talked to you about as atypical antipsychotics, which are augmenting drugs in OCD. And fewer were taking a benzodiazepine, that is something like lorazepam or clonazepam, which are used for anxiety. 6 in both groups were taking an atypical antipsychotic, for example, Risperdal or Seroquel. And 10 in both groups had failed to benefit at all, much, from prior trials of SSRIs and were benefiting inadequately from the SSRI they were now taking. So this is their second or even later SSRI to which we added amphetamine or caffeine. Next. At the end of week 1, roughly half of both groups were doing well enough to continue. And in fact, they were doing dramatically well. They had a mean drop in their Y-box score of 40 to 45%. And 4 of the 6 who were responding to amphetamine had a drop of more than 35%, and 5 out of 7 in the caffeine group, a little bit more than in the amphetamine group, had a drop of 35% or more. Of course, we still didn't know, and they didn't know, whether they were getting amphetamine or caffeine. To make sure that people couldn't tell, we had them rate how much they liked the drug and how high they felt on the drug. So that if the amphetamine group, for example, felt very high and the caffeine group didn't feel high at all, or not much, that would say, well, maybe the blind isn't working. But this looks like the blind was working. After this first week, the drops in the Y-box score did not correlate with the drops in generalized anxiety rating or in depression rating. So they were independent of the anxiety getting better or the depression getting better if it did. Next. At the end of 5 weeks, after that 4-week extension, one patient during that time on amphetamine dropped out because she felt that the benefit she was getting, it was 20, 25%, but it wasn't enough, and she didn't wish to continue. But the change in Y-box score from the beginning in both groups was substantial. You can see the mean, the average, was 40 to 50%, a little larger in the caffeine group than in the amphetamine group, surprisingly. And it went anywhere from 20% to 80%, which is a huge drop in a Yale-Brown scale score, and to 90% up in one patient who got caffeine. At the end of that time, we guessed, before we broke the blind, what did this patient get? We were no better than chance. And the patients guessed, and they were even worse than chance at guessing whether they got amphetamine or caffeine. It tended to be that if they were getting caffeine, if they got better, we guessed they were getting amphetamine because we thought caffeine was a placebo. Side effects were mild. A few people had transient insomnia. A few people had transient nausea that went away. And a few people, we had to drop the dose because their pulse rate went up on both the caffeine group and in the amphetamine group. Next. Well, was this a placebo response in both groups? Probably not, because remember, there were those 2 controlled trials in the 1980s and 90s that were placebo-controlled, and placebo groups didn't respond. And when you add a dopamine blocker like Seroquel or Risperdal to an SSRI, and in the other group you give a placebo, only about 10% of the placebo groups in those trials get better on placebo. Whereas our rates of getting better were 40 to 50, just almost 60% in these 2 groups. And also, our response came quickly, and it was sustained. And in general, in psychiatry, placebo responses don't come on quickly. And if they do come on, they're not sustained. It may be important to know, if you're going to be given or take a dopamine blocker, that within 1 week at any given dose, you get what you're going to get from the dopamine blocker. You don't need long trials like you do of serotonin reuptake inhibitors. to know what a dopamine blocker is going to do for you. Well, we think it was both D-amphetamine and caffeine were both working. It turns out, which I didn't know at the time when I chose it as a placebo, that both dextroamphetamine and caffeine release dopamine, a stimulating drug which helps people pay attention. And they both increase working memory. And the patients in both groups said, gee, doc, I still get my obsessions, but I can turn my attention away from them, which I couldn't do before. And because I can get away from them, I don't have to do my compulsions. So both caffeine and dextroamphetamine had the same subjective effect in the patients in whom they worked. Next. Let's turn away then from dextroamphetamine and caffeine, but I would tell you that you might talk with your doctor about a caffeine trial, because that's simple, and you'll know in a day or two whether it's working, and you buy the caffeine in pill form over the counter. But let's talk about glutamate antagonists. Glutamate is an excitatory neurotransmitter in the brain, and there's some thought that because certain brain circuits are overactive in OCD, it's due to too much glutamate stimulation. So glutamate antagonists were used. This one is memantine, used in Alzheimer's disease, as I mentioned. And there were 2 studies. The first one done in our clinic by Dr. Aboushadi, who's now the director of the OCD clinic. This was open label, and he gave 14 patients memantine, started at 5 milligrams, which is a low dose the first week, and every week go up by 5 milligrams to 20. And 6 out of the 14 patients responded. If they didn't respond by the end of week 4, by the first week when they were getting 20 milligrams, they didn't respond. So a 1-month trial is long enough to know whether memantine works. There was a second study where people were hospitalized in a residential treatment center for OCD on the East Coast. And the staff compared the people who got memantine with roughly 18 milligrams a day versus people in the same treatment setting who didn't. About 2/3 of both groups were getting an SSRI, and they used as their outcome, did the Y-box scale drop by half or more? And in the memantine group, that was about 1/4 of the people, 1 in 4 people. In the control group, it was 1 in 20 people. So memantine really seemed to have an effect. Next.
Harry, just wanted to remind you that we're maybe 4 or 5 minutes away.
Okay, we'll be there. We'll get there. Next. We'll skip the other memantine study. It's important just to know what I told you. We'll go to lamotrigine, which is used for epilepsy. And this, if you look, these were 2 treatment-resistant studies, fairly large, 40 in one, 22 in the other. And in both studies, if you look at the 4th line down, you can see that lamotrigine had dramatic effect in people when it was raised gradually to a dose of 100 milligrams by the end of week 4, or 200 milligrams by the end of week 8 in those trials. Many people had a marked response. Next. The last drug we're going to talk about is morphine, taken once a week. Again, I had read some literature suggesting that morphine might work in some case studies. And with people not getting well in the OCD clinic, we decided to do a double-blind trial of this. I had read this study from Canada where 5 patients given morphine once a week got better for 5 to 8 days. And there was also a study of tramadol, another opiate, where similar results were reported. Next. So we enrolled 23 patients with chronic OCD that had failed at least 2 serotonin drugs. They were moderately severe to severely still affected by OCD. They continued taking whatever they were taking, and they had been on stable doses for 8 weeks. And they were given random in order 2-week trials of oral morphine once a week, oral lorazepam once a week, or placebo once a week. And in both groups, they got 2 capsules so that we could either increase or decrease the dose by a capsule if they didn't get better or if they had side effects in that first week. Next. You can see that 7 of the 23 people who got morphine once a week got better. That is, their Yale-Brown score dropped by at least 25%. All of these people were taking a drug, an SSRI or a serotonin norepinephrine drug. None of the people who were not taking any other drugs got better. And the only difference between sort of responders and non-responders, other than taking a serotonin drug, was people who were also taking a dopamine blocking drug were much less likely to respond to oral morphine than the people who were not taking it. So 1 out of 7 taking a dopamine blocker responded. 6 out of 17, 35%, who were not taking one of those responded. If they responded in the morphine group, 5 out of the 7 had their Y-box drop by at least 40%. And in the lorazepam group, where there were 4 responders, only 1 had a response that big. The patients said that the way it made them feel better was not the day they took morphine, or they said the next day they noticed they were having fewer OCD obsessions and it was easier to get away from them. That's in contrast to amphetamine and caffeine, where it works the day you take it. And then the response to morphine would last for 4, 5, 6, 7 days and then go away. Many of these people continued on once weekly morphine for years without losing the effect, without needing more and more morphine in drug addiction. It just once a week morphine worked for them in addition to their serotonin reuptaking drug. There were no placebo responders in that trial. And with that, I'll stop and wait for questions during the question period.
Thank you so much, Dr. Koran.